Respiratory system, auscultation. Introduction. The patient's history determines the scope and intensity of the chest examination. When the history elicits suspicion of the presence of a chest problem, the physical examination of the thorax must be expanded beyond a minimal screening examination to determine the nature of the problem so that a diagnosis can be made. Technique. The pulmonary examination consists of inspection, palpation, percussion, and auscultation. What to observe during auscultation? Breath sounds, vesicular, broncho-vesicular or bronchial. Vocal resonance, bronchophony, whispering pectoriloquy, egophony. Added sounds, pleural rub, wheezes or crackles. Procedure. Introduce yourself and confirm the patient's identity. Explain what is going to take place and ask for consent. Auscultation of the chest is generally done with the stethoscope diaphragm and is ideally performed in a quiet room with the patient either sitting or standing. Listen to the anterior, lateral, and posterior thorax. Comparing one side to the other is a helpful maneuver to identify the patient's normal. Position the patient's arms over the head to listen to the lateral sides. When the posterior thorax is examined, the patient's arms should be crossed anteriorly to move the scapulus laterally as much as possible. Assess the intensity, normal, increased or decreased, and quality, vesicular, bronchial, or broncho-vesicular of the breath sounds. Vesicular breath sounds are heard on the periphery. Bronchial breath sounds are heard normally over the trachea, the upper sternum, and paraspinal areas of the upper thoracic vertebrae. They are often loud and high-pitched. Vesicular breath sounds. Broncho-vesicular breath sounds. Bronchial breath sounds. Confirmation of the presence of bronchial breath sounds can be obtained by listening for egophony, E to A sound. This sound is elicited by asking the patient to say the letter E as one listens over the suspicious area with the stethoscope. When consolidation is present, the spoken E sound is audible as an A sound, similar to that produced by a bleating goat. Check the vocal resonance by asking the patient to say 99 while ausculting the upper, middle, and lower areas of both lungs on the front and back side. When the sound appears to be near the earpiece of the stethoscope, known as bronchophony, suggests that the sound is traveling through a mass of fluid. Vocal resonance is decreased in pneumothorax and emphysema. It is increased in consolidation. Ask the patient to whisper 1, 2, 3 to assess for whispering pectoriloquy. A clear and audible 1, 2, 3 could indicate a consolidation. There are 3 types of abnormal breath sounds. that arise in the pleura and in the lung. Frequently, they are collectively referred to as adventitious breath sounds. Pleural rub. Wheezes. Crackles. Carefully examine the areas that revealed abnormal findings during palpation and percussion. In a dyspnea patient, it is best to auscultate the abnormal areas first, that is, the lung bases, in case the patient becomes fatigued during the examination. Physical findings must be interpreted in the light of all previously collected data. The general scheme is to develop a postulate and test it with further history, additional observations or maneuvers on physical examinations and laboratory tests.